The SPRINT MS trial was a phase 2 clinical trial of ibutalas, which is an oral therapy being evaluated for progressive MS. It was a 2-year trial evaluated in 255 patients, recruited from 28 sites across the United States. So it was a good-sized phase 2 trial. The primary outcome was a biomarker, whole brain atrophy, asking the question, does ibutalas therapy lead to a slowing in the progression of whole brain atrophy? And into the trial we recruited patients with both primary progressive or secondary progressive MS, and either of those phenotypes were allowed into the trial. The overall results of the trial, we found that ibutalas was associated with a 48% slowing in the progression of brain atrophy compared to placebo, which was quite a startling and surprising finding of that magnitude. It was quite a dramatic slowing in the progression of brain atrophy. That then led to the question of, was there a similar decline in, or slowing in primary progressive as secondary progressive? Now, those two phenotypes have been considered separate for a long time, and indeed most clinical trials enroll either primary progressive or secondary progressive MS patients, and typically don't enroll both. We enrolled both based on a growing sense in the field that there is much more similarities between primary and secondary progressive MS than there are differences. And there's a growing sense that they're very, very similar in overlapping phenotypes. So we looked at a breakdown, and by chance we enrolled roughly half and half of primary and secondary progressive MS patients. Again, the trial was open to enrollment of whoever, and just whoever came in is who came in, but it ended up being roughly half and half. So that allowed us to have rather good power to look at the differential treatment effects in primary versus secondary progressive MS. And what we found is that the overall results were driven predominantly by patients with primary progressive MS. And there was essentially no slowing of brain atrophy in patients with secondary progressive MS. So the benefit was in patients with primary progressive MS. When we looked at what factors might have been driving that, was it because of a difference in baseline brain volume, or a difference in T2 lesion volume, or age, or things like that, we really couldn't find any explanation other than their categorization of primary versus secondary progressive MS. The one thing we did observe which pointed towards a potential explanation is that the rate of atrophy in the placebo groups was over twice as fast in primary progressive MS as secondary progressive MS. And that hasn't really been well understood. It was rather surprising that the rate of atrophy was twice as fast, more than twice as fast, in the primary progressive patients. And so it may have been that the secondary progressive patients just didn't have enough atrophy progression to show a potential beneficial effect of a therapeutic intervention. So we may have seen somewhat of a floor effect. We don't know how that relates to a phase 3 trial, of course, in terms of whether there will be a differential clinical benefit in patients with primary versus secondary progressive MS. And for that, we'll just have to wait for the phase 3 trials.